Welcome to Understanding New Ways to Prevent and Resolve Crises. I resolved my own crisis yesterday. I went to Jacob Riis Beach and I remembered to put on some 30 SPF because otherwise I would have been 5 times the shade of this shirt. But I'm delighted to have you all here today at the first workshop. We're joined by 4 champions in the field. And, you know, this term crisis has become a hot button issue, right? I mean, we live and breathe it every day, but it also has had so many negative connotations related to everything from subway safety to homelessness. We don't really talk much about how to help our tenants think about crisis, plan for it, think of ways to work through it, ideally prevent it. And that's really what we're here to talk about today, is to give you some tools and also hear about what's going on a policy level. So I'm delighted to be joined by my friend and colleague, Deborah Cumberbatch, Vice President from S.O.S. We have Luke Sikinyi from the Alliance in his new role as Director of Public Policy and Advocacy or Engagement. Carol Hurd is from ACMH. Carol is doing the work on the streets with an S.O.S team directly with people impacted by homelessness. So she's a peer specialist on the S.O.S team. And Chris Smith at the end there, Associate Commissioner from OMH. And Chris is going to talk to us a little bit about what's going on a policy level, particularly around what we've been talking about with respect to discharge planning from folks who end up in the hospitals or emergency rooms or CPEPs, how we can have a more interactive relationship with housing providers and hospital systems. So we're going to start with Chris, then move over to Carol, Deb, and Luke's going to end us up. And what we'll do is we'll hear from each of them. If you have a burning question and you want to get it in early, feel free to raise that, but otherwise we'll take some questions at the end. Okay, so thank you so much, and I'll welcome Chris.
I had to do my slides in a weird way, so it took a minute to get them started. So welcome everybody. This is an amazing crowd. This is such a fun conference to have so many people all here who are all focused on supportive housing. And I just want to thank you all for what you do on a day-to-day basis to help people get homes. And OMH, I'm going to talk about a lot of our resources, but in everything we do, we hope and we know and has meaning and helps people with serious mental illness. But housing is really, I think, the most important thing that we do, because if people don't have home, you know this, but I'm going to say it out loud anyway because it just bears repeating. Without homes, people are so limited in how they can accomplish their other goals. And so all the work that you do to help people get housing and keep them in housing is just amazing and so important. So just thank you so much for what you do every day. So I'm going to talk about really a systems approach and what we've been doing to increase resources in the community to help respond to and prevent crises. But also, resources all by themselves can only do so much if everything isn't knitted together into a better system that communicates and really supports people and helps people move from level of care to level of care. So we'll talk a little bit about some changes we're doing around that to support that. So, as I'm sure you've heard, if you've heard OMH talk about anything recently, it's been about the $1 billion budget we had last year from Governor Hochul's executive budget. And it's really a historic investment. I doubt we'll ever see something like that again in our careers, even though mental health continues to be a priority in incoming budgets. So some of the things that really, in addition to all the programs, the focus of all of that work has really been around improving access to hospital care and systems accountability, providing 3,500 beds of housing for people with mental illness, expanding community services, expanding homeless services for homeless people, and strengthening children's services. But there were also a bunch of cross-cutting kind of themes across this, just systems focus. So strengthening the mental health workforce, expanding insurance coverage so people can access the services and get reimbursed better for the services. We have a very strong focus on integrated care. We're working very closely with OASIS, OPWDD, and DOH to make sure that because nobody just has one thing. Almost nobody just has a mental illness. Most people have a multitude of issues and concerns. And so we have to get out of our silos and provide better care across and among those spectrums. We're always focused on equity and diversity in our programs and lifespan programs. We set aside at least 25% of those services to focus on young people. And we're also doing more to try and support older people in the system. So I'm going to start with, since this is a housing conference, just start by walking through where we are with all of the new housing resources in that budget. So there was a really major expansion of housing services, developing 3,500 new housing units. And within that, though, there's a real strong emphasis on housing first and integrated services. So with that housing first model, what we mean by that is we issued some beds where with a low barrier to entry, but also a higher level of funding to be able to hold beds, to have them available so you can move people into them when they're ready, and also supports to let people people aren't always ready to move into housing and stay there. Sometimes they leave and then need to come back. So with that extra funding, we're hoping that providers will be able to hold those beds available for people and let people do what they need to do to come into that housing. Okay, thanks. Sorry about that. And then, so some of the specific programs we're doing there, which are coming up now, are short-term transitional residences. These are like 3 or 4 month long stays with intensive supports to help people who need that extra support to really get ready to get into housing and just get a little bit more stabilized, get a little bit more supports, and then be able to move into housing. So these will be for people who are coming out of hospitals, coming off the streets, things like that, and need some intensive work, and then be able to move into housing. And on we're specializing some of these programs in some ways. We RFP'd for 6 programs that are. We expect all of our housing programs to focus on both mental health and substance use, but these are really going to have an intensive focus on people who are having more serious mental health and substance use conditions and supporting that during the transition. We're also building some transitional programs for people with both mental health and developmental disabilities. And we're also having some of these programs specifically to serve people coming out of prison and in jail. So this is just a quick snapshot of our 50,000 units of housing across the state. Most of it is the scatter site supportive housing and SPSRO housing, but we also have a lot of the licensed housing as well. And we also have a really new emphasis on homeless services. You're going to hear from Karen about the S.O.S. team and how that's working. That's a really important initiative that we started a couple of years ago. We started it in New York City, and now it's throughout the state. And these teams are really an interesting kind of hybrid model. So they combine like street outreach, so engaging with homeless people where they are. In New York City, they're focused on working in the subways. And then they have a critical time intervention model, which is a kind of a stage-based, short-term intensive engagement and kind of care management process where you work with somebody for 9 months to a year and really engage with them intensively up at the beginning, help them get into their system of care, get the resources that they need, and then kind of step back over time and support them in ensuring that system is meeting their needs. So the S.O.S. teams have been doing a great job with that. They've had tens of thousands of outreach encounters, gotten thousands of people off the streets and into shelters and safe havens. But very importantly, and these numbers are out of date, at least 400 individuals have moved into permanent housing from these teams, which is just fantastic. And we have 11 new teams outside of New York City all over the state now. And it's going to be different there, and so those are new challenges that we're working out. I'm just going to hit a number of the ways we're expanding. So these are resources you're probably mostly familiar with, but we're expanding them throughout the state. And these are resources that housing providers can take advantage of, that your residents can take advantage of. So we want to make sure you're aware of these for the work that you're doing. In addition to the S.O.S. having a critical time intervention model, we're developing teams across the state that have a very focused CTI approach. These are mostly going to be working with people coming out of hospitals, but they can also serve other populations where, in parts of the state where there isn't an S.O.S. team, that they'll hopefully be able to serve homeless individuals as well. And it's that same approach of the 9 to 12 month phased period where you're really engaging people and helping make sure that their services are in place. So we have 15 teams downstate, 10 upstate, 4 rural teams. They're small teams that focus on those areas. And with the IDD and mental health transitional housing model I mentioned, we're also attaching CTI teams to those to serve those individuals, but also serve the broader community of individuals who have challenges with IDD and mental health. We've expanded our ACT teams. I'm sure most of you are familiar with ACT teams. It's a mobile treatment and care coordination team. They meet people where they're at. It's people who don't do well in clinics and regular sort of place-based settings. We've expanded and diversified these programs. We've expanded the number of regular ACT teams, but we've also started doing more specialty populations. So we have ACT teams serving young adults. We now will have statewide scope of ACT teams serving people with criminal justice involvement. We have a couple of ACT teams in New York City who serve only older adults. And we've started a new model of ACT serving children and adolescents. And then we've also, these aren't special populations, but we've started rural ACT teams, again, like a smaller ACT team, because rural areas have challenges with staffing and also not having as many people to serve. So we have now smaller ACT teams that can serve rural areas. And we're trying a new thing with ACT to make it more flexible and allow an ACT team to expand their capacity to serve people and help them step down by serving them longer and being able to move them up and down the sort of continuum as they're getting ready to discharge them to the community. We work very closely with OASIS on this program. It's a CCBHC, a Certified Community Behavioral Health Clinic. This is a federally funded program. It's a really great clinic model. It's fully integrated mental health and substance use services, but it also has other services like psych rehab, case management, peer services, crisis services. So we're in the midst of tripling the number of these programs around the state. We had one RFP and are adding 6 new CCBHCs in New York City and 7 in the rest of the state, and another RFP is out on the streets right now. And in addition to these community resources, we've also done some hospital-based resources. So we put out capital funding for new inpatient units and CPEPs. So we're adding 9 inpatient units and 9 CPEPs, both in New York City and in the rest of the state. So that's all the resources. But the point of all of this is not just to have more resources. I mean, resources are great and we need more resources. But if they're just standalone, if people aren't communicating, if hospitals aren't talking to community providers, if community providers aren't talking to hospitals, if housing providers aren't talking to the clinics, et cetera. So we're really trying to increase and improve that. And with all of the system changes that have happened over the last few years, COVID, bail and parole reform, telehealth, the opioid epidemic, the landscape that we're living in has really changed. And so we're really seeing the need to not only have more access and better access, but to knit everything into a more coherent system. And so one of the ways that we're going about doing that is by trying to establish clear, consistent expectations for the entire system of care, for how to assess people, how to communicate, and what the admissions discharge practices should be, and really trying to bring hospitals and community providers together to figure out how to improve that collaboration on an ongoing basis. So we've released guidance document for hospitals, and we're incorporating changes in regulation to enforce that guidance document, and those are already in place. We also released a community community guidance along the same lines, and we're in the process of finalizing that, and we'll ultimately update all of our program regulations to incorporate that too. But I'm just gonna hit the high points just so you get a sense of what this guidance is focused on. And it's really all relevant to what we're talking about when you think about preventing crises. So, because we all see the hospital system has changed with things like managed care, with all of the changes in acuity that we see on the streets and in our programs. And often, it seems like people who need to get admitted to a hospital don't, or people get discharged too quickly. So we're focusing on improving things like screening and assessment processes. We're trying to make sure that hospitals do the right thing, do a thorough assessment, and take all of the factors into account when making a decision on whether or not somebody needs to be admitted. And part of that also is about collaboration and communication. So, I mean, like when you guys refer somebody or call 911 and somebody's taken into the hospital, we want to make sure the hospital calls you, that you send information with the person to explain why you're sending them to the hospital, but also that they call you to get your point of view. Why did you send the person? But that also means you have to answer the phone and have somebody available who can share that information. Because, you know, when we talk to hospitals, they say, well, nobody answers the phone when we call. And when we talk to community providers, they say, hospitals never even call us. So we have to get everybody on the same page locally and really start figuring out how you can, the whole systems can communicate and collaborate better. And it also applies to discharge planning. If a hospital discharges somebody back to your housing but doesn't tell you that they're coming, how they're doing, and prepare you to accept the person back into your housing, they may lose their housing. They may never make it there. They may go back to the streets. Some other things may happen to them as well. So we're really focused on that as well, and making sure they're sharing the information with you. And y'all can be part of the plan. Y'all can be part of the process for discharging. And similarly, we have community guidance. It's separated a little bit for treatment providers, care coordination providers, and housing providers. The themes are very similar, but just a summary of what the expectations will be for you. Very common sense. Nothing should be terribly controversial, I don't think. Communicating and collaborating with hospitals and providers, as I mentioned, we need you to make sure you have strong practices in place to be able to communicate with a hospital, that you have people who can answer the call and have access to that information. And for some programs where you have 24/7 staff, probably not the scatter site programs, but more focused on our licensing programs. You'll be able to have somebody within your agency who can answer a call if somebody goes into the emergency room at 2 o'clock in the morning, and you can say, you know, what's going on with this person and help them make the right kind of decision. If you have safety plans, if you have recovery plans, we want to make sure that you share those with the hospital so they know who this person is, what their goals are, and what you have in place with those people. And same thing with coordinating aftercare and discharge planning. We want you to be involved and talk to the hospital while the person is there. We want you to make sure that you know what's going on when the person's going to be discharged. If you can share information about what helps that person, who they are, and what their resources are, who their community is that the hospital can speak to. After discharge, we want you to support people when they come back into housing. Make sure, to the best of your ability, to help make sure that they make it to their aftercare appointments and help them reschedule appointments if they don't make them, things like that. So, and to make all that happen, we've already started doing all over the state these community meetings where we're bringing together different interest groups, hospitals, housing providers, treatment providers, to start doing this work. And we're actually investing in hiring a number, like 50, 60 new staff to spread around the state and engage hospitals and community providers in building these relationships better. So stay tuned for, you'll be seeing more of that happening in our system. So with that, I will turn it over to our next speaker.
Thank you so much, Chris. So as I mentioned, the crisis has become a real working issue. There's no shortage of issues going on, but this conference alone has 3 workshops on crisis today. So there's one on overdose prevention. This afternoon, my colleagues from Correct Crisis Intervention, NYC, are going to be talking about how to get more peers into the first responder situations with crises on the streets. But when I spoke to Carol as we were preparing this workshop, Carol's really doing the harm reduction work, right? She's out there with lived experience on the streets. Something that's struck me about this program is there's no diagnosis required. We're not talking about labeling people, we're talking about finding ways to get to people and to help change their lives. So let's hear a little bit more from Carol about the work she's doing. And you're going to stay at the table, or you want to come on up?
Oh, it doesn't matter.
It's up to you. Okay, let's welcome Carol.
Good morning, everyone. My name is Carol, and my organization is ACMH, S.O.S. Outreach. My position is a peer specialist, and what I do every day is I go out and engage with clients in the train stations or even outside, and we talk about trying to house them and help them with other services, safe havens, if they need a 311 call, or 911 call, and maybe an emergency call for the hospital. Some of them may have some kind of we have a nurse on staff, and maybe they need to get a patch up on the leg or whatever, but we help support a member by offering services. So what we do, we ask them first if they want to go into a safe haven. Some of them might want to, some of them might not want to. So when we do house them, we offer other services like primary care, psychiatrists, doctors, documentation, a therapist, and some of them is undocumented, and we offer services with that. We take them and escort them to get their documentation, like Social Security card, a birth certificate, an ID. And once we offer the services, we give them the transportation as well. So once we house them in permanent housing, we continue to engage with them there. And to prevent any kind of crisis, what we do is we give them other resources and services. So we just basically try to change lives of others, and it's happening, and it's a good thing to do. So we support We support them with their mental health diagnosis, their disabilities, and we build trust with them as well. That's the first thing. We've got to build the trust. Okay, thank you.
Carol. Thanks so much, Carol.
Thank you.
And I was curious about how you form those relationships. I mean, what do you first say to people who may have been hard to engage on the streets?
Well, what we do, we try to offer them the services first, and we offer them food or what have you, or clothing if they need it. And if they accept it, that's how we continue with our conversation.
And do you get to the point with some folks who perhaps are ready to make the next step to housing, and what do you do there?
Yes, once we house them in the safe haven, from there, you know, they stay for a little while. We offer them other services. We can continue to communicate with them. We go visit them, and we go from there.
Terrific.
Continue to engage.
Thanks again.
You're welcome.
So Deb and I were talking a little bit about planning for crisis, helping people develop safety plans. I think that's a key issue these days, is identifying a safety plan that is collaborative, that has the best wishes of the tenant, has their support system involved, the key players that they want on that plan, and then getting folks to recognize those safety plans if they are ever needed to be in action. So I know S.U.S. have always done a lot of terrific work on this. I've always turned to S.U.S. for ideas on cutting edge issues, and let's hear from Deb a little bit more about the work that's going on.
Good morning, everyone.
Good morning.
Can you hear me? Yes. Great, thank you. So we're going to start with first looking at policy, planning, and practice. So I strongly suggest, if you don't have it already, that you should have, and I'm going to use a less passive word and say you must have a crisis plan. You must have a policy that support your staff around managing crisis. You should be practicing what that policy entail, which should include a code, so that staff would know in the event that if they use a particular word, that it means that I'm in trouble, I need help. So we'll start there. Planning. Housing opportunity. S.U.S. referred to people coming in for housing as housing opportunities, not necessarily screenings or interviewing, but a housing opportunity. And at that point, we begin an orientation with the person. Crisis management is when we start crisis management at that point. Something that's not new, is old, is the RAP plan. And so we introduce a RAP plan, and we talk about advanced directive, empowering people to start from the beginning of the relationship to do some self-determination and being a person-centered organization. This fits well with our practice. So people get an opportunity to hear about a RAP plan. And with that, they're given that choice from the beginning, how they want their crisis to be managed. We also talk about a safer use plan. In terms of harm reduction, we're offering people a plan that helps them to kind of identify how they would like to look at safety with use. You know, the old day we'll talk about, you know, substance use, and we'll talk about, you know, abstinent, we'll talk about things that really didn't work very well, and it kind of shut people down. We really couldn't have a conversation. But when you introduce a safer use plan, you could introduce it as if it's something you need or if it's something that someone you know may need. But it's an opportunity for people to start thinking about safety around use. So those are the first steps that we start with. As we move into practice, We train the staff, and we train all staff, not just clinical staff, all staff. Maintenance, cooks, whatever staff is on site need to understand how to de-escalate. So we teach everyone, we train everyone on de-escalation, and we train everyone on trauma, so that people understand how they can either themselves be activated by an event that can escalate it, or how the person could be escalated by us triggering them, activating them. So those trainings are vital to crisis management. We also support people around debriefing. When an incident happens, a crisis occurs, we have to debrief. We have to talk about what went well and what didn't go so well. In that whole process with training staff, it's important that everyone start to report on things that doesn't seem normal with a person. If you see that the person you normally engage with, whether it's security or maintenance, the people that they usually spend more time with more comfortably, right? If you notice that there's a little bit of agitation, staff is trained to bring that to our attention, because that agitation can be the first sign that we're going into crisis. Isolation is another big sign that we're going into crisis. And so if all hands are on deck and we're all paying attention to these different changes within the people that we're working, we're able to better respond. Crisis is also managed best when we connect people to support. Integrate them into the community. Some people are very open to therapeutic support. Some people are more open to natural support, but we are having those conversations, and we're bringing some of those supports into the building. There's a lot of activities around volunteer work. There are different programs that come in, and you have pet day where people get to spend time with pets, play with animals, and do different activities. So the main thing is that as crises are occurring, we need to be one step ahead of it as much as possible. We also need to be able to let me look at my notes. I'm getting a little old here. Yeah, good. So I wanted to talk about zero tolerance for violence, because I think it's an important part of crisis management. As organizations out there, we have to really set policies around zero tolerance for violence. And I know we've come in, we're evolving as supported housing, as providers, working with people. I remember the days when, you know, a person we support may physically harm a staff or their peer, and we would go through these different things around, you know, it's the diagnoses, they were, you know, experiencing symptoms and so forth. We really have to create safe work environments for the people that's coming into work and for the people that live there. We're all equally important, and with a level of accountability, when people are violent in our building, we should not discourage the process of holding people accountable. People have to feel safe in our buildings, right? So it's very new to some of us. I know it was very new to S.O.S. Our practice was, you got punched in the face, we stroked your back, we understood that I really didn't mean it, Deb didn't mean to hit you, Jim. And, you know, we offer you an opportunity to transfer to another location for your safety, and that doesn't work anymore, right? We know that we have a lot of issues with workforce retention, right? We're working with limited staff. Staff turnover has been also a part of the crises that we're dealing with. So we have to make sure that we're making people feel safe and that people have the right that if they're going to press charges, that they should press those charges and not feel like, you know, and OSHA is forcing that as well, right? OSHA no longer wants to hear that this is my behavior and I come back and apologize. Because when staff feel threatened, it's a violation of their rights as well. So as we begin to talk about crisis, we really have to be open and we have to really talk about what are the realities of some of the people that we're experiencing as we work with low barrier to placement. We're experiencing a lot of increase in violence. We want to be able to prepare for that. So again, I'll go back to the housing opportunity. It starts then. It's a real chance for us to do orientation around some of the expectation, providing that support, engaging people into their own planning of their own services, but at the same time setting the expectations around what we will tolerate and what we won't tolerate. So I yield at that.
Thank you, Deb. Can I ask you, could you give us an example of a type of safety plan that you've developed that has worked for folks? And how has that worked?
Well, with the Safer Use Plan, it works. We haven't been able at this time to give numbers because, as you know, with the overdose rates climbing, we're experiencing it at high levels in S.O.S as well. And we've employed harm reduction specialists. We're moving towards educating our staff, training our staff on harm reduction. But what we were more focused on was the number of deaths. And we were trending and looking at those trends. And what we're not focusing on, or what we are focusing on, what's become a part of our dashboard now, is the number of people that we have saved lives using Narcan. So the practice has always been counting the number of people that we lost and not how many people that we have actually rescued using some of the life-saving support that we have with Narcan, fentanyl. We're putting those things out. So we've seen people really starting to make more of a connection with the Safer Use Plan, because it's not telling people not to use, it's really helping them to think about who they're using with, who they're purchasing from. If they're using a loan, on that form there's a number that they can call to be monitored during the time of use, and we find that to be effective. 97% of the people we serve have a RAP plan, and we really try to follow all the instruction, establishing that trust, that we will contact the family, we will contact the person you identify, we will work with your primary or your natural support before we make that 911 call. We make that call when things are at a point where it's a safety issue. But once there's no safety issue, we kind of follow those plans accordingly. So the RAP plan has been very effective. The Safer Use Plan has been very effective. And just training staff on how to de-escalate and how to work with people, and not the first time I scream, yell, or throw a chair that I'm going to experience the trauma of police running in the building. Sometimes we just give people an opportunity to kind of step back and kind of calm, and then we pick it up at a time when they're able to have a conversation. Wonderful.
And on a harm reduction level, did I hear that you're exploring vending machines?
Oh, S.O.S have a vending machine. It's located at, it's in Brooklyn. I'm trying to make sure. See, I got a whole thing. It's on Decatur in Brooklyn. I was trying to get in Brownsville, Bedford-Stuyvesant. There you go. And so the vending machine offers, you know, from, I call them nice little feminine kits, to things that you can use to use safely. And it's also, as you enter your zip code, you're also able to connect with a counselor who can then, support you wherever you're at with your recovery. So when we talk about crisis, these guys will make me talk too much. They, not only do we have the vending machine, but we have like 5 community refrigerators, because we're also looking at food safety as a crisis response too. And so people coming into our homes now, we're looking at, instead of just all starter kits with things that people really don't use in the long run, but creating food basket. We've piloted at one program, and we hope to roll that out. So when you talk about crises, a lot of times people coming in from the shelter system, they're not adequately prepared for housing. So we give them these wonderful starter kits that they can cook, and they could do all these wonderful things, but they don't have the food to cook on the first day. So my boss is in the back, so that's one of her models, and we're really pushing that ahead. So these are the ways that we're looking at crisis. So crisis is not just set on behaviors, but it's also the environment that we create, is the opportunities that we offer people, is how staff respond to issues, is the policies that we set. It's around accountability for everyone.
Wonderful. Thank you, Deb. So now we're going to turn to Luke from the Alliance, formerly NIAPRIS, and Luke has been doing a lot of work around planning for crises, debriefing post-crisis. What do we do after an incident happened? How do we get people with lived experience more involved in that process? And also the concept of psychiatric advanced directives. We hear a lot about medical advanced directives, but not so much about how to get a mental health advanced directive into the mix too. So let's hear from Luke. Welcome.
Thank you. Yeah, thank you. I'm really happy to be here with you all today. My name is Luke Sikinyi. I am with the Alliance for Rights and Recovery. First and foremost, I am a person in mental health recovery, a peer, if you will, and I also work as the Director of Public Policy and Public Engagement for the Alliance. The Alliance formerly the New York Association of Psych Rehab Services, or NIAPRS, as many people know us by. We recently went through a name change, as well as going a little bit national to do more federal legislative work to support our members who are people who use and or provide mental health and substance use services. So a lot of the work that we have really been focusing on recently has been around crisis. We look at it in a real continuum basis. So we think about things in the form of first prevention, then crisis intervention, post-crisis management, and then finally our real goal, which is sustained recovery in the communities of people's choice. So I'm going to go through a number of initiatives that we have been working on, and I'm going to go through it in a little bit different way than most folks here. I'm going to talk about what's currently available, what's in the pipeline, and then what we're really working to bring about from a policy angle for the future. So the first thing I do want to note is we are really in the crux of multiple crises. We are seeing mental health conditions really skyrocketing and having more people not connected to services, more people who want services being unable to access them from the beginning. We're also seeing at the same time a massive workforce shortage. That is the one thing that we are constantly hearing about when we are talking to members, when we are going to Albany. That is very, very clear that our workforce has been one of the biggest issues that has created this compounding crisis. And then the last is we are also sort of at a crisis of image. I think in a lot of ways the mental health and substance use field, we've been seen as folks who are helping people in need, helping the most vulnerable of communities. But recently that trend has really been turning more towards labeling people with mental health challenges as violent, disruptive, people who do not need to be in the spaces of community. And we all here know that is not correct, that people need services, people need support in order to live well in the community. But what we see with that image is a lot of policy shifting because of it, and also the response from the public. Some of the things that we have heard, especially from housing providers, is the difficulty in getting new housing, partly because neighborhoods are saying no, or landlords are saying, well, police are coming here too often. This is causing too much disruption. Or there's a possibility of violence, or they fear that if we put a supportive housing unit here, my apartment is going to get destroyed and I'm going to have to do X, Y, Z here. So we're having to really focus on all of these different issues while just trying to provide support for the people who we care for and really want to help. And one of our goals is really to wrap around some of that support housing providers and providers of care by offering more supports, not just to individuals, but to the providers themselves. So a couple of ways that we've begun doing that is through a project with the Office of Mental Health, who I will take a quick moment to say thank you so much for all of the work you all have been doing. Not only the $1 billion from the governor, which once again, thank you, this is a historic investment, but the speed at which OMH has been putting out that money, putting out programs, because they are very clear in the goal of trying to get support out to people as fast as possible. And we can't do that without the funding, and we can't do that without their dedicated work to make sure that funding gets out the door. So some of the things that we have seen, first and foremost, is the Peer Core Navigator project. This is a project that the Alliance has taken on with OMH to really allow our peers, who are people with lived experience of the mental health system, to support more people who are eligible for core services. CORE is the Community-Oriented Recovery and Empowerment Program. That is a version of the HCBS program from before that really focuses on people within Medicaid who could get better services and access more. So we have a lot of core providers, but what we've seen is a lot of people are struggling to connect with core providers. So what the Peer Navigator project does is we will be the people who will connect you all. So instead of having to get someone who's working in the housing program to have to go and figure out where the core providers are, figure out how to get someone to services, what we say is don't worry about that. You can either call us or have the individual call us directly, and we will connect with them. We will meet with them, we'll determine what sort of services that they want, what they're eligible for, and even if they aren't eligible for the services we provide, we'll find services that they are eligible for and are helpful to them. So we'll take that off of you all and be able to do it for us and then connect them directly with those services. And we'll work with them, we'll come to people, meet them in your house, in the apartment, in the community, wherever we need to help get them to those services. So this is not only a support for people who are in recovery or trying to gain recovery, but also providers who might not have as much staff to go find these resources or connect people to those resources. This is an easy way to connect all of those. For those of you who are interested about calling, the phone number is simple. It is 855-PEER-NAV. 855-PEER-NAV, and we do have a table out here to connect you all if you have more interest in that service. Another thing that we've really been pushing for and see more and more popping up is peer crisis respites and general respite programs. These are huge for us because we know a lot of people begin to get close to that critical acute crisis moment, but there's a step before they're in need of a hospitalization that they get to where if we can intervene there and prevent them from either disrupting their current community or feeling like where they are right now is becoming more of a stressor, getting them into a peer crisis respite not only allows them some time away from that space that has been stressful, that is causing that crisis, but allows them to get that relief and then gain the skills to go back into their community and be able to manage their challenges so that they do not enter into that full-blown crisis moment. So we're really pushing to expand peer crisis respites as much as possible. We've seen the state really sort of provide more funding for this, but we know that much more is needed. If you call a peer crisis respite right now in New York City, I can tell you that most of those beds are completely full. And the reason why is they are successful, they are helpful. People really enjoy these, and they feel like this is a much better setting, a much more home-like setting than a hospital, where oftentimes people are traumatized, have been traumatized before, and are just afraid of even the concept of going to a hospital because they don't want to go through that again, which only furthers their crisis. So to talk a little bit about some of the things that are on the way and what we're really excited for, the first is the INSET model, which is the Intensive and Sustained Engagement Team model. This is slightly adjacent to some of the work that OMH, S.O.S, and other S.O.S teams have been doing about engagement before people are in crisis, or engagement to support people who are otherwise eligible for court-mandated treatment or Kendra's law orders. So one of the things that we have seen is the level of engagement for folks who are often seen as unengageable is really the core of what we need to support people. We've seen a lot of really great success with the pilot program for the INSET program. This was done in Westchester through the MHA of Westchester County, and what they found was 86% of those folks who otherwise were deemed unengageable and should be mandated to treatment, they did engage with the peers who were going out on the street, going to clinics, going to bus stops to just see, you are currently unhoused. What can I do to support you? What do you want? So that we can start with what you want and then begin to wrap these other services. It's hard for people who are on the street to hear about you need treatment when they don't have a home to go to yet, or they don't have food to eat at the end of the day. So being able to take care of these needs before getting to treatment and getting into services or detox, these are critical to getting people to even be open to the support. And what we found is people want the support, they want the help, but they need it to be fashioned in a way that they want and that they desire. And so we want to make sure that that is the goal here. And what the INSET teams are able to do is work with folks who are eligible for Kendra's law orders and begin to get the services in place so that they don't have to be on that Kendra's law order, so that they're not being pushed to jails or institutions, but rather really supporting their recovery in the community. And part of that is housing, but part of that is also us wrapping other services around. You all are one part of a much bigger whole of the person to really get them the needed services that they will strive in the community with. The next thing I want to talk about is really more about a post-crisis work, and it's both post-crisis and pre-crisis. And this is something that we have been working on at the Alliance for the last year or so, and that's around psychiatric advanced directives or mental health advanced directives. So for those of you who do not know, mental health or psychiatric advanced directives is a form that indicate that you fill out as an individual when you are well, and you indicate what you would want and need when you are not well. So when you're in that point of crisis and you might need to be hospitalized, what hospital do you want to go to? Where have you had the best experiences? The last time you had this experience, what kind of medication worked? What kind of medication didn't work? I can identify that in my psychiatric advanced directive. I can upload that to Psyches and then have my providers, whether it's the housing providers, know that I have that on file. So if I get to that point of crisis, I can have you print that out, and when I go to that hospital, I have it on hand. But even better than that, we can have that in that file so that no matter how you get to the hospital, those doctors, those nurses, they see, okay, this person has a psychiatric advanced directive. Let's see what helps them, what gets them well as fast as possible, and let's do that. So what we've been doing, New York has a psychiatric advanced directive on file, but it has been a little bit, the uptake of it has been slow, and part of what we saw was that it was confusing. It was difficult to fill out. It was not as strong legally to guarantee that these are the services or the medications and that people are going to find or follow this plan. So what we've done over the last year is work with a number of lawyers to update this so that it is easier to read, easier to complete, and much stronger legally. And we have been speaking with the Office of Mental Health and Department of Health to really revamp this, get it approved by the state, and then really roll it out with an implementation strategy of making sure peers can help other people complete this, providers of housing can help people complete this. This can be a simple intake process. You've figured out you want housing. Let's look at what your plan is for a crisis. Let's have that psychiatric advance directive on file. Let's have your RAP plan on file so that we know, okay, these are the stages where, sometimes I'm beginning to steep into a crisis. I start getting way more talkative than usually. I start throwing things, or before that point, really recognizing the signs of when a crisis is beginning, and then knowing on file, no matter who the worker is on that time, these are the things that kind of soothe me and help me get back to wellness. So that's something that is in the pipeline, and we're working very heavily to make sure that gets passed or that gets updated and we are able to roll it out to everyone. I now want to talk a little bit about some policies that we've been pushing for that need some continued advocacy, and I will let you know right now we are going to be continuing that advocacy over the next year to as long as possible to get these things in. The first is around crisis response. You can hear a little bit more about this from CCIT NYC later, but our goal is really to change who the first responders are for mental health crises. With police as the standard, this causes a lot of problems. I began my work in the field as a direct care worker, and one of the things I will say from my agency at the time, we had a policy that calling police is the very last resort, because it not only traumatizes the individual, we don't know what's going to happen after the police come, but the rest of the community has a massive disruption. For those folks who have had these negative interactions with police, or those folks who are just afraid of that negative interaction with police, seeing 8 officers walk into a building for one individual after we've already de-escalated the situation is never a good thing for the community. We also know that, people who have a mental health crisis, people who are of color, our black and brown community, often are disproportionately disproportionately have violence committed against them by police officers. We see that people who are shot by police officers are more than likely have a disability and are black. So we know that these negative interactions are possible and often happen when we call police. And we know from decades of knowledge here that police are not the best people to respond to mental health and substance use crises. And who are? We believe that it's peers and EMTs, people who can address the health issue if there is a health issue, and people who are well trained in de-escalating the crisis and understand where people have been, understand how this goes for folks, and have that compassion and that empathy. And most importantly, this is their entire job. We're asking police to do 1,000 different jobs outside of just public safety, and they're not trained for it. They're meant to have control of a situation, and it's not about empathy and making sure that people are doing okay and taking that hour-long time to get to a point that you are well enough to go to another place or the crisis is resolved. So what we want to do is really advance the number of alternative responses available to everyone. And this does, so we're doing that first, we're doing that through the push for Daniel's Law, which would create a statewide system of non-police mental health responders. So they would respond in mental health and substance use emergencies when there is no incidence of violence, no weapons. So these are calls that police are not required to be at in the first place. And one of the things that we have talked to housing providers about this is around the issues about having police come to a location so often, having an emergency services come so often that it disrupts the neighborhood. With these sorts of responders, what we can do is we can call people before it's full-blown crisis, before there's a public safety issue, so that we can resolve that crisis or that pre-crisis or approaching crisis situation in a way that doesn't disrupt the community. It doesn't remove the individual immediately unless they want to be removed, unless that's the best next step. But it also means that you don't have all these records of 911 has come here every day for the last week because somebody here had a crisis. Instead, you have a community responder who doesn't come with massive sirens and disrupt the neighborhood and disrupt the community, but rather is coming with compassionate resources and then can follow up with individuals afterwards so that they get not just the current crisis care, but that post-crisis care as well. So this will be huge for our state, not just for folks who are in housing, but for folks on the street, allowing us to have that second group to call that doesn't make us fear about what happens after they come here. The next thing I really want to talk about is our goals for expanding the Peer Bridger program. Peer Bridgers are folks who are peers once again, but they are really focused on bridging people from hospital back to the community. So after people have gone to the hospital, oftentimes one of the biggest issues with discharge is there's no one there to really walk with you when you're coming back into the community. No one there to help you reintegrate and understand what you need in the community, even if you don't necessarily know it. You know, a discharge plan is great, but not having someone to call to figure out, okay, this service didn't work for me, what can work, that is huge. So our Peer Bridger program, which we've had since the 1991, has really worked out of state hospitals, but we're trying to expand it to work out of community hospitals as well, so that people not only have a place to go with housing, but have that secondary support of a peer bridger to help them wrap all those other services that are needed as they get back into the community, so they're fully integrated and are really achieving their wellness. And we work with people up to 9 months after discharge. So this isn't just a warm handoff of 2 weeks, but rather we're going to stick around, we're going to be there for you, and we're going to make sure that you are not going back into the hospital. And we've seen massive reductions in recidivism for the hospitals. And we want to expand this also for reentry services for folks coming out of jails and prisons, so that they can be better situated in their community, have that needed support so that they're not going back to institutions, whether it's a hospital or a jail or prison, but making sure that they have everything that is needed to be well in the community. So really the goal here is to offer everyone, including providers, that additional resource, that additional person to help to ease this transition, and also to work with providers of different organizations, different institutions, to be able to be that one person who says, okay, I can work with this individual and help them, empower them, coach them, so that they can be able to manage all of this. But while they can't, I'll be there to help them manage it until they're at a place that they can do this on their own. So I'm going to pause there.
Wow. Thank you so much, Luke. Such incredible stuff on your agenda there. And I love that term that you mentioned, fashioning the help, and what that looks like for folks. It's a really key term. So we've had our presenters. We've got time for some questions, and I'm sure there are some folks in the audience that would love to ask a question or two. We do have a mic in the center of the room, and I don't know if we have a passable mic at all, or we ask people to come up. I have some questions, but I'm going to start with you guys.
Hi, my name is Noah Shaheen. I'm the program director for
Hello? Is that it?
No.
Hello?
I think that.
Yeah, that's better.
Better. Out.
Hi, everyone. My name is Noah Shaheen. I'm the program director for supporting housing for single adults, SRO. So I had a few questions regarding the programs like ACT Team, CTI, Safe Option Support, or even like the Peer Bridger. All these programs are really great, but what I find very hard is like referring the clients. The eligibility criteria, like 2 hospitalization, 3 hospitalization a year. Even though I will be advocating for my client because I know I have worked with them, I know what they need, the hospital, the social workers would not be listening to me because of the eligibility criteria. So how can we help clients enroll to these programs? Because I know they will benefit from it. I know case management for like intense case management for like 6 to 9 months, our client will benefit from it. But how can we break that like eligibility criteria and be able to support the client enroll to these programs because they are great?
Great question. Thank you so much. Maybe Chris and Luke, I don't know if you want to respond to that.
Yeah, I mean, there's a lot of programs out there that like you're describing, and I mean, care management and the like health home care management. There's a pretty low bar for eligibility for that. So that's one place to start. Like anybody with a serious mental illness, that's all they need, and they're eligible for health home care management. ACT is a little more. There is that higher bar, but your organization can refer somebody for ACT directly. So every county has a single point of access process where you can submit an application directly to the county, and that's it doesn't have to go through the hospital. So that's something you can do directly. So if you reach out to you're in the city? Yeah, reach out to DOHMH and their SPOA team, and they can help you complete a SPOA application. And they've also broadened that. It's for ACT, but it's also for their IMT teams, which are like they're more intense ACT teams. But they're expanding it because so many people apply for ACT. When other things can be helpful, and so that they also refer to any number of other programs. They're starting to refer to PROS programs if somebody's eligible. They'll refer to care management. They'll refer to clinics. So they will also they're shifting their focus, not just about ACT and care coordination. That's what it was historically, but they're broadening it to make it more responsive and help people get to the services they need. So that's a great place to start.
Yeah, I would also encourage you to get connected with one of our New York City core peer navigators, partly because the whole reason for this project was a lot of people not knowing what they were eligible for and not knowing what was available if they weren't eligible for the things that they did know were there. So part of what we do is we talk to people about what they need and then cater what they're eligible to based off of what they're needing. And we will refer to core services. We'll also refer to other services if needed. But the goal was really to get people the care that they desire in any way possible, and making sure that we can be that bridge between you all and the service that they really want.
And one more thing about core services. They're really cool. It's kind of like an a la carte list of services. It's not ACT is bundled. They do a lot of different things. So core, if somebody just wants a psych rehab service, they can get it. They don't have to have anything else. They have to be in a heart plan. That's the floor for core. But all of those, there's peer services. They can get standalone peer services. They don't have to be in a clinic. But there is like a mobile treatment service. But they're in community services. So they go to the people where they are. So in addition to the help that they can provide in linking people to other services, core is a really underused and great program.
Thank you.
All right, so a couple of good ideas there on how to expedite referrals. Yes. Hello.
Hi, I'll make this quick. My name is Alexandra Francis. I'm the Chief Program Officer at Lantern Community Services. So first, I just want to thank all of you for your presentation. It was really right on time. The question that I have is for you, Deborah. We are like-minded in terms of zero tolerance for violence. But I'm curious about S.U.S.'s approach because, as we know, our clients are leaseholders. And there are challenges that we face with our funders when it comes to, we may be zero tolerance, but our funders may not be. And I'm specifically thinking about HACA, for example, where we have to go through a case conference process. So I'm wondering whether S.U.S. employs any other strategies beyond supporting staff. If they want to engage law enforcement, are there other strategies that S.U.S. utilizes?
Yeah, I mean, we start out with what we call a conduct letter. So everything that you mentioned, with HACA, you have the HACA process, right? And OMH is very supportive. Often we call OMH when we have situations, and we kind of work through it and we come up with a plan. But we started with conduct letters, and those letters really highlight the behavior and the violation of the lease. And so we give people an opportunity. We say, okay, here's the behavior. Here's how we can support you around those behaviors, right? And we're also building a paper trail. And so after 3 conduct letter, we move towards holdover. And everybody know that you can have 6 months of behavior. You get to court a year from now, there's no behavior. So the idea is not to make people, formerly homeless people, homeless, but to set the expectation and the standards around what's tolerated. So if within the time we reach the court, those behaviors no longer exist, perfect. But if they continue, we're going to move towards eviction. And so the letter has to be really clear about how we as staff can support you around the issues that you're having, right? And a lot of it has to do with coping skills, because most of the behaviors are results either due to substance use or sometimes psychiatric. But it's really around coping skills. But some people, not everyone we can serve. And so we try our best to serve everyone, but we also work with those conduct letters and keep reinforcing in the community what's expected and what's acceptable and what's not.
Yeah, great question. And, really focusing on the plan of correction for that notice of violation or conduct letter, as we've heard it called, not just pointing out the deficits, but what you can do differently and how those behaviors can change. That's the beginning of the paper trail, ideally. Hello.
Hi, my name's Allison Golden. I'm a case manager for Housing and Services Incorporated. And my question is actually for Chris. I think it's really great that there's a resource list being sent out to hospitals on how to collaborate with community care better, because I think there's a major communication breakdown that happens. And I don't know if this is relatable to anybody else, but one of the major things that I experience is that hospitals will try to discharge really high-risk clients, either medically or psychiatrically, on a Friday or on a weekend when none of us are on site to accept them, and it just causes re-entry into hospitals pretty much immediately. So I was just wondering if there was any communication with hospitals regarding why that's such a bad practice, because it seems like the social workers at hospitals don't understand that.
Yeah, I'll make sure we're incorporate absolutely that's but I mean that's part of where we're trying to go with this, is getting decisions to be made in rational and collaborative manner, not just meeting. I'm not I mean, everybody's challenged and doing the best they can, but come on. I mean, you got to do things that make sense and respect the person and their system of care and lead to a successful discharge. So I'll make sure that's something that is very important. It's probably come up. I mean, I hope you all are starting to be in some of these meetings and kind of convenings that I'm talking about, and raising it with the hospitals themselves. And so we're really going to be trying to support those collaborations among the community and the hospitals. But thank you for that specific one. I'll make sure it gets back to the team and
Great.
it's
Thank
on their
you so
list.
much.
Yeah, and that term that you used earlier, Chris, about answer the phone, I think that's a key, right? I mean, we have a world out there of CPEPs, ERs, inpatient units, and figuring out who those people are, who the right people are to call, who's available after 4 o'clock on a Friday. Those are all key elements.
Hi, my name is Johanna Arbaiza, and I'm with Barrier Free Living. I'm a behavioral health coordinator. This question is mostly for Luke. You mentioned an alternative to AOT Kendra's law, and you mentioned more about about homeless people, like that's what you referred to, like the unhoused. I'm more curious about what programs are going to be available for AOT or AOT candidates who have homes.
Yeah, so the Inset program is actually for anyone who would be eligible for an AOT or currently on an AOT. So it is not specific to people who are experiencing homelessness or through the shelter system. It is for anyone who would be eligible for that court order, and it is ramping up. I will say that the governor put in $1.6 6, I believe, for 4 teams throughout the state. There is a team in Brooklyn that is going to be ramping up. There's a team in Westchester that's ramping up, one in Long Island, and I believe they just were able to procure another team in the central New York and western New York area. So these are going to be online before the end of the year, and we're hoping to expand them even further in the next budget session because we are seeing that it's working. It's just a little bit of a process to get some of these teams on the street, but that will be available to anyone who has an order or is eligible for an order.
So it's basically addressing basic immediate needs with wraparound services? Is that the model?
Yeah, essentially it's voluntary engagement supports, so they will be doing many of the wraparound services that are critical to maintaining your wellness in the community, and there's also a lot more individually tailored supports for things like if you're dealing with parole or dealing with other criminal justice involvement or other involvement in institutions, making sure that that's coordinated as well.
Okay. All right. Thank you.
Hi.
Hello. I work with the YWCA in White Plains. I oversee 193-bed women's residence. This message is for Chris. My question may be a bit specific, so let me know if you could refer me elsewhere, but I'm new to working Westchester. I come from city side of things, and I'm wondering what, if anything, is being done to support White Plains Hospital specifically with regard to responding to mental health crises. From what I understand, they're not really equipped. Even the EMS personnel will tell me Westchester Medical Center is the place to go, but they don't take them there, and it's sort of a revolving door cycle. So what, if anything, is being done?
I don't know. That's a little more specific than I can answer.
Yeah.
But I'll give you my card, and I can connect you with our Hudson River field office, and they'll be able to help you. So, sure.
Hi guys, Steve Psychiatric, Supportive Housing Network of New York. Thanks for doing this, A. And B, question for Carol. Can you talk about what you are looking for from residential programs as you help people transition in from the streets? And then the opposite question is, what should supportive housing in particular, but all housing programs, be looking for from you as a peer working for an S.O.S. team, which could really be any kind of support services field team?
So what we're looking for is just to support and engage the members in, changing lives of others. And what look for within us is, maybe it's the mic. Okay. Okay, can you hear me? Okay, now you can hear me. Just basically like changing the lives of others and supporting the members out in the community.
All right. I know people are vying for a seat at lunch, but we'll take another question. Yeah.
Okay. Hi, my name is Robert from S.U.S. This question is for Luke. Regarding engaging people that are challenging with the peer now, is there a set number of visits or is it time limited on the engagement process?
For inset, no, there is not. The goal is to go in, the way that we look at it, and when we were creating this program, it was really about being intentional and being persistent. So, sometimes the first couple of times is not when people engage, but maybe it's knowing that person's going to be out here every day at this bus stop, every time I show up to the bus stop, and they're going to keep asking me what I want, what I need, and trying to figure out some angle here. And the goal is to really engage as much as possible until that individual is comfortable, and then figuring out the plan from there. Because once you get someone to open up a little bit, you kind of pull and pull until, okay, this is what you really want, this is what we can talk about. And then once they gain that trust and feel like, okay, they are actually really addressing the things that I'm saying, not just trying to push whatever they want on me, you end up seeing people really engage and then become more willing to look at certain services. And that's been fantastic. I know with the Peer Navigator program, which is separate from the inset, that one is more about making sure people get the right kind of services. And for folks who go to a core service, like it, but they want something else as well, they can come back to us and say, okay, this worked, but I'm also looking for this sort of service within to support this need or this dimension of my wellness. Can you help me there? And then they will. They'll try to make sure that we can get them into any sort of thing that will help them that they want.
Thank you.
Okay, yeah, one more. Yeah, come.
Then the mic will come to you.
So sorry. My name is Lisa Marie Braxton. I'm from ACMH, and nice to see another ACMH staff member here today. Chris, unfortunately, this may be more directly to you, but in our program, we have a client who's been in and out of the hospital for about 24 times in the past 6 months. Recently, one of the hospitals have told us that they were discharging him because he threatened to kill a nurse. And we asked for a case conference. We basically told no. And when I said, you're releasing someone back into the community that's a danger to self and others, their response was, we should call it NYPD next time. And I can't because he's doing this out in the community. So I think this is something just to kind of echo about hospital and agency collaboration. This is a major concern that we're having. A lot of times it feels like the hospitals just want to kind of wash their hands of it, and then the program has to figure it out from there.
Yeah, no, we hear you. And there's, it's behavioral, we hear that a lot too, and we're working on changing that mindset. And again, if you don't mind sticking around after, let me get the specific information on that from you so we can follow up, because that's not how our system should be functioning, which is obvious to everyone except maybe them. So yeah, that's.
And one other tool is the field office has a risk committee.
We did that too.
Yes.
OMH is try to get them connected to a substance. I don't even do field work, and I was in this man's apartment on Tuesday, surrounded by trash.
There you
and
go.
the guy, hardly wants to talk to us. He agreed to go to substance, but now we can't find him. So.
Okay. Well, thank you for all you do. Let's give a round to this amazing panel of champions. Thank you for coming, everybody.
You bet.
Saves pleasure.
I have mine.